Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on one lung ventilation in special scenarios. You can watch this lecture and other lectures by visiting my YouTube channel using the URL at the bottom of the slide. The learning objectives of our lecture is to have a brief account on pediatric one-lung ventilation, one-lung ventilation in patients with difficult airways, patients with a tracheostomy in place or post-laryngectomy requiring one-lung ventilation, patients with intra-operative one-lung ventilation requiring post-operative mechanical ventilation, and hypoxemia during one-lung ventilation. We start with pediatric lung isolation. When compared with adult anesthesia, pediatric thoracic anesthesia can be more difficult due to the wide variety of pathology and the size limitations of available lung isolation devices. Lung isolation is not always necessary for pediatric thoracic surgery. Many surgeries can be performed with conventional tracheal intubation. Unless contraindicated, the preferred lung isolation device for patients over 8 years of age is the double-lumen endotracheal tube. While under the age of 8 requires the use of a bronchial blocker or endobronchial intubation for lung isolation. All pediatric bronchial blockers should be considered to have high-pressure balloon cuffs. Therefore, extreme care is required during placement and inflation. Slinger, the editor of Principles and Practice of Anesthesia for Thoracic Surgery, teaches that there are the ABCs of adult lung isolation: anatomy, bronchoscopy, and chest imaging. In pediatric lung isolation, there are still all the same ABC considerations, with the addition of D, the varying diameter of the pediatric airway with age. The preferred method of lung isolation in the adult population, a double-lumen tube, cannot be used in infants and small children because of the smaller airway size. When choosing a bronchoscope to be placed within a tracheal tube, there are two questions to ask. The first question: what size bronchoscope can I use that will physically fit? And question number two: what size bronchoscope can I use and still ventilate the patient? The options for lung isolation in children include the followings. Number one, single lumen endotracheal tube. Number two, bronchial blockers. And number three, the double lumen endotracheal tubes. The bronchial blockers include the Fuji Systems uniblocker tube, 5 French, suitable for children up to the age of 8 years. Ardent bronchial blocker, size 5 French. Number 3, the Univent tube. Number 4, vascular balloon catheters in the airways, such as the Fogarty embolectomy catheters and the Miller atrioseptostomy catheters. Well, most of these devices have been already discussed in previous 2 lectures. But for completeness of the subject, we wish to review these devices again. So bronchial blockers are the preferred method for ages 2 to 8 years using the coaxial technique. In the coaxial technique, the bronchial blocker is inserted inside the endotracheal tube. And they are the preferred method for ages 6 months to 2 years using the parallel technique. The parallel technique, like the one shown in this picture, the bronchial blocker is placed outside the endotracheal tube. And this difference is due to the difference in the airway. So infants 6 months to 2 years, they have small airways. Therefore, the bronchial blocker is placed outside the endotracheal tube. While children 2 to 8 years, they have a relatively bigger airways. Therefore, the bronchial blocker is placed within the relatively larger endotracheal tubes. Bronchial blockers are acceptable method for ages 6 months to 18 years. For more details about the bronchial blockers, you can see our lecture on the YouTube using this URL at the bottom of the slide. This is another lung isolation device suitable for children called the Fuji Systems Uniblocker. The Fuji Systems Uniblocker size 5 French is suitable for children up to 8 years. In this method of lung isolation, endotracheal intubation is performed in the conventional manner, just like a single lumen tube, and one lung ventilation can be achieved by placement of this blocker to either the left or the right lung, or sometimes to lung segments. So this is the Fuji system uniblocker, which is introduced either within or outside the endotracheal tube. Alternate endobronchial blocker, or the wire guided endobronchial blocker, is another device which comes in different sizes. Size 5 French is suitable for children, and as we have discussed before, there is a multi-port adapter, and there is the blocker passing through the single lumen endotracheal tube, and there is a loop which couples the fiber optic bronchoscope for proper placement of the bronchial blocker within the bronchial tree, either the right or the left stem, main stem bronchus. And in the next slide, we'll see a brief video demonstrating the insertion of the of an extraluminal bronchial blocker, the ardent bronchial blocker, in a 9-day-old infant.
Reproduced with permission from Dr. Wes Templeton, showing their technique for one lung ventilation using a 5 French ARNT endobronchial blocker on a 9-day-old baby for one lung ventilation. First, a direct laryngoscopy is performed and a bent aunt endobronchial blocker is inserted through the glottic opening and advanced until it meets resistance. An uncuffed endotracheal tube is then inserted through the glottic opening anterior to the aunt endobronchial blocker. After confirming bilateral breath sounds, the endotracheal tube is secured. The neonate is then placed in the left lateral tuberculous position and a fiber optic scope is inserted through the endotracheal tube to visualize the bronchial blocker. Notice that they don't use the multi-port adapter that comes with the aunt endobronchial blocker. After confirming the position of the bronchial blocker in the right mainstem bronchus, they inflate the bronchial blocker cuff under direct visualization to achieve successful lung isolation. They make it look so easy in this video.
Well, after watching this brief video, we resume our presentation. So the other lung isolation device, which can be used in children, is the univent tube. The univent tube shown in this picture is the preferred method for ages 6 to 8 years and an acceptable method for ages 6 to 18 years. The univent tubes are available in two pediatric sizes, 3.5 and 4.5 millimeter internal diameter. The other devices are the vascular catheters, such as the Fogarty embolectomy catheter and the Miller atrioseptostomy catheter. Both catheters may be placed either within or outside the endotracheal tube. The Fogarty catheters come in varying sizes and they are more commonly used than the Miller atrioseptostomy catheter. The Miller atrioseptostomy catheter comes in 5 French size, suitable for pediatric use. The other type of lung isolation devices is a double lumen tube, which consists of 2 lumens. Unless contraindicated, the double lumen tube is the preferred lung isolation device for patients over 8 years of age. And for more details about the double lumen tubes, their advantages and disadvantages, you can see our lecture by visiting the URL shown at the bottom of this slide. So the double lumen tubes are the preferred method for ages 8 to 18 years and also an acceptable method for this age group, 8 to 18 years. Often considered the gold standard for lung isolation, the double lumen tubes or DLT is suitable for children older than 8 years of age. The equation of size equals age multiplied by 1.5 plus 14 can help to estimate the sizing needed. The smallest double lumen tube size is 26 French, which is generally suitable for children 8 to 10 years of age. The single lumen tubes is another method of lung isolation in children. They are the preferred method for ages 0 to 6 months for small infants, and also an acceptable method for ages 0 to 18 years. So they are suitable for children of all ages. The simplest option for lung isolation is to place an SLT or single lumen tube into the desired bronchus. This technique can be used at any age and is the most common option for the very young patient. Placement of an SLT in the right mainstem bronchus is easier than the left due to the less acute angle that it takes off from the trachea. Flexible fiber optic bronchoscopy will greatly aid in tube placement. Well, there are some pros and cons for the SLT. The mainstem intubation with an SLT has the advantage of being simple and quick, while the disadvantages of using an SLT for lung isolation include potential for inadequate collapse of the operative lung, inability to suction the operative lung, and inability to deliver continuous positive airway pressure, CPAP, to the operative lung. And given the short distance between the right mainstem bronchus and right upper lobe bronchus, ventilation may be limited in the right upper lobe when the right mainstem bronchus is intubated. Well, now the second subject in our lecture is one lung ventilation for difficult airway patients. Well, there are some tips that help to solve this problem. Optimal patient positioning and adequate dose of muscle relaxant with sufficient time prior to direct laryngoscopy to obtain ideal intubating conditions. Direct laryngoscopy with the use of specially designed bougies for double lumen tubes, video laryngoscopes, rigid optical stillates, standard orotracheal intubation with single lumen tube followed by exchange for a double lumen tube, using specifically designed soft-tipped double lumen tube exchange catheters, and the use of fiber optic bronchoscopy, whether in the awake or asleep patients. The third subject in our lecture is patients with a tracheostomy in place or post-laryngectomy. What are the options to achieve one lung ventilation in such patients? Removal of the tracheostomy tube and inserting a conventional double lumen tube through the stoma. Removal of the tracheostomy tube and insertion of a single lumen tube through the stoma, followed by a bronchial blocker. Passing a bronchial blocker coaxially through the cuffed tracheostomy tube. Replacing the tracheostomy tube with a specially designed short double lumen tube called Naruki double lumen tube. And lastly, removal of the tracheostomy tube and then doing a standard orotracheal placement of a double lumen tube or bronchial blocker, which is not possible after in a patient with post-laryngectomy. So there are many options to solve the problem of achieving one lung ventilation in such patients. The other subject that we want to discuss in our lecture today is patients with intra-operative one lung ventilation requiring post-operative mechanical ventilation. If the surgical procedure hasn't been a lung resection surgery, double lung ventilation or bilateral lung ventilation can be safely resumed in the post-operative period. To achieve that, there are two options. The double lumen tube can be exchanged with a standard single lumen tube over an exchange catheter under direct laryngoscopy at the end of surgery. The other method, both lungs could be ventilated in the ICU with the double lumen tube in situ. But here, the bronchial cuff should be deflated as soon as permanent two-lung ventilation is established to reduce bronchial mucosal damage caused by the low volume, high pressure bronchial cuff and any potential airflow obstruction that could be caused from the bronchial cuff herniating over the carina. So you have two options, either to replace the double lumen tube with a single lumen tube or to keep the double lumen tube but deflate the bronchial cuff and resume bilateral lung ventilation. Now we have a problem observed during one lung ventilation, whether in children or in adults. Whatever the isolation, the lung isolation device used is called hypoxemia during one lung ventilation. So immediately after the initiation of one lung ventilation, there is a fall in arterial oxygenation and saturation, which gradually picks up as hypoxic pulmonary vasoconstriction increases. Hypoxic pulmonary vasoconstriction is a regulatory mechanism. While there is no accepted figure for the safest lower limit of oxygen saturation during one lung ventilation, a value of 90% or more is recommended. And for management of hypoxemia during one lung ventilation, we'll see a brief video in the next slide.
Hello, and welcome to the Pediatric Anesthesia podcast. Let us first discuss the pathophysiology of hypoxemia during one lung ventilation, which is caused by venous admixture through shunting and areas of low VQ exchange. During one lung ventilation, the collapsed non-dependent lung is essentially an obligate shunt. Shunt and VQ mismatch also occur in the dependent lung secondary to gravity-dependent perfusion and atelectasis. In the lateral position, when both lungs are being ventilated, the distribution of pulmonary blood flow is such that the dependent lung receives 60% of pulmonary blood flow, while the non-dependent lung only receives 40% of the pulmonary blood flow. With the institution of one lung ventilation, the non-dependent lung becomes atelectatic and alveolar arterial oxygen tension decreases. This results in hypoxic pulmonary vasoconstriction, in which increased pulmonary vascular resistance diverts blood towards the dependent lung, thereby decreasing the degree of shunting. Hypoxic pulmonary vasoconstriction is an autoregulatory reflex mechanism that reduces the pulmonary blood flow through the non-dependent lung by 40 to 50%. Factors that modify the hypoxic pulmonary vasoconstriction response during one lung ventilation include hypotension, hypocapnia, hypothermia, and to a minimal degree, the use of anesthetic agents. At doses of less than 1 mAc, volatile anesthetic agents have a clinically insignificant effect on hypoxic pulmonary vasoconstriction. On the other hand, nitrous oxide is a potent inhibitor of hypoxic pulmonary vasoconstriction and should be avoided during one lung ventilation. Infants and small children are more susceptible to hypoxemia during one lung ventilation. Compared to adults, infants and small children have a more soft and compressible rib cage, resulting in their functional residual capacity being close to their residual volumes. In the lateral position, this increases the risk of airway closure even during tidal breathing. In addition, the infant's relatively small body size will result in a decreased hydrostatic pressure gradient, which normally increases perfusion to the dependent lung. The management of hypoxemia during one lung ventilation is as follows. First, increase the FIO to 100% and notify the surgeon to stop non-urgent surgical procedures. Then, take the patient off the ventilator and hand ventilate to assess lung compliance. Then confirm the position of the bronchial blocker with a fiber optic scope and perform alveolar recruitment maneuvers if necessary. Subsequent steps may include increasing PEEP to the dependent lung or adding CPAP to the non-dependent lung. It may be necessary to intermittently reinflate the non-dependent lung if the above maneuvers do not resolve the hypoxemia.
Well, what are the take-home messages of our lecture? Lung isolation is not always necessary for pediatric thoracic surgery. Many surgeries can be performed with conventional tracheal intubation. The preferred lung isolation device for patients over 8 years of age is the double lumen tube, while children below 8 years require either a bronchial blocker or an SLE, the single lumen tube. Patients with an anticipated difficult airway requiring one lung ventilation can present extreme challenges to the anesthetist. A team approach could be helpful, and several options are available to increase the chance of safe and successful lung isolation. Similarly, there are many options for patients with a tracheostomy who require one lung ventilation. Patients with intra-operative one lung ventilation requiring post-operative mechanical ventilation have two options: exchange of the double lumen tube with a standard single lumen tube, or using the double lumen tube for ventilation of both lungs with deflation of the bronchial cuff. While there is no accepted figure for the safest lower limit of oxygen saturation during one lung ventilation, a value of 90% or more is recommended. Hypoxemia during one lung ventilation in most cases respond to some simple interventions. And this is the bibliography used in the preparation of our lecture. And with this nice photograph of Sulaimaniya city in the region of Kurdistan, Iraq, I conclude my lecture. Thank you for watching and listening to the lecture. This is Professor Abdulsalam Yasin Taha signing off from the College of Medicine, University of Sulaimani.